Hey guys, do you work in emergency medicine? An absolutely crazy and intense environment where you see things every day that a regular person doesn't see once in their entire life. Do you feel burned out, unappreciated, like there's no one you can talk to about the things you are struggling with? Well, you are not alone. I have a bunch of real professionals with real stories here with me today that can relate to your struggles. I've struggled with burnout, discouragement, and frustration many times and still struggle with it occasionally. My name's Aaron. I've been in emergency medicine for 15 years as an EMT, paramedic, and now emergency medicine PA, and I am the host of the Practical EMS podcast. We've got some new guests with us today and some returning, so we're going to jump right in and do some introductions and talk about some awesome topics today. So let's go around and we'll just start with Kylie. Just introduce your first name, your credentials, and the length of time in emergency medicine. And then if you have a story that like inspired you to get into emergency medicine, but you don't have to. And then we'll kind of go around. And I guess those of us that are returning, maybe we'll skip the stories part and just remind everybody about our credentials.
Keep in mind, he called you a professional, so just fake it till you
Try it.
Okay.
What's up, bitches? And swivel that mic a little closer.
Okay. My name's Kylie. I am going to be starting as a nurse practitioner. I've been an RN for 10 years, CNA before that. So I've pretty much done the nursing spectrum. I've worked in a slew of places: med-surg, emergency medicine, interventional radiology, neurointerventional stroke, all sorts of fun stuff. Story-wise, it was something new to try. I don't know.
How long were you in the ER for?
Oh, I've been in the ER. So I've been in a few different ERs since 4 years.
Oh, nice.
So,
Okay.
yeah.
Very cool. And Casey.
Oh boy.
Hi, Casey.
Hi.
Hi.
I'm Casey. I'm a paramedic. I'm pretty new at it.
Started yesterday.
Yeah. I think I'm the odd person out. I've never had any of that burnout or discouragement or anything. So
We'll help you through the burnout. when
I'll
we
be
get
bringing
there.
that positive attitude to the discussion today. No, anyway, I've been doing this for 47 years and counting. So anyway, that's it.
Cool. I'm Aaron. I'm an emergency medicine PA, and I've been in emergency medicine for 15 years. Hopefully you know me if you're listening to this.
Short, sweet.
Yeah. I'm Adam. I'm an emergency medicine physician. I was introduced to emergency medicine out of sheer desire to experience some adrenaline. Somebody told me when I was a lost 19-year-old to go get my EMT and see what the ambulance was like. So it started there, and then the fire department, and then the medic. And then at some point, a nice big gap for college and med school, and have now been involved for the better part of between education and otherwise somewhere in the 15 to 20 year mark. Been in the ER as a physician for the last almost 9 now.
Sarah?
I'm Sarah. I'm a paramedic. I've been a paramedic for about almost 4 years and in EMS for 8. I can't believe it's been that long. Casey was one of my trainers, so that was really cool.
Sorry about that.
No, she's really good. She really is.
She's a good kid.
Yeah, she really is.
I
Despite-
kind of fell into it. I actually started the company I work for. I started in the billing office. And I
Oh,
was
that's
gonna
right. I
go
forgot
down-
about
Yeah.
that.
Yeah, I was gonna go down like accounting
Forgot about
path.
that.
And we had to do a ride on the ambulance as like part of our job, and that's when I fell in love. So immediately after that, I was like, I'm going to school. So
I forgot about that part of your origin story.
yes,
That's
for
good
me.
for you.
I like the origin story. Here I
The
am.
central theme of, sorry, Nate.
I was
You
like,
go ahead.
fuck
I was about to
me,
interrupt you.
I forgot I'm the
I've had to
EMT,
listen to
I
you and
don't
Casey
matter.
and Adam introduce yourself so many times at this point.
So I'm Nathan. Hopefully all you guys know me. And I'm the EMT. And I'm not that smart compared to all these people.
He's the EMT extraordinaire.
When I read you, I was like, yeah, it's stretching it a little bit, but I have my ACLS. I just don't want to use it.
How long have you been in emergency medicine now?
9 years.
9 years.
And I just started in the hospital.
Yeah, we'll have to chat about the difference between field EMT stuff and hospital, because a lot of people have that question.
Oh, yeah. I'll
You
gladly
want to talk about it right now?
I don't care.
Yeah.
Yeah,
Why don't you talk about the transition? Because I find a lot of EMTs kind of want to know the answer to that. So
It's great. I don't have to do shit. It's amazing.
Yeah.
What?
Your bosses might want to be watching this.
I'm kidding.
I'm really working. I work. That's what you should say.
Oh, okay.
I'm working a lot.
I'm of course kidding. No, I mean, it's been wonderful though. Like, I mean, you know, I sit there like, and I help out where I can. I have my orders that we put in. I do the labs. I help out with ortho. You know, like everyone's been so welcoming to me and it's been amazing. And then if I need help, like I can ask 2 or 3 different more people for help. And if they need help, I'll gladly go help them out. And then whenever my section's done, I'll go over to the other units to just help out. Like the transition has been different because usually on an ambulance, you just work, you know, and then here, like I sit here, I grab blood, I go get urine samples, I do the fluid testing. You know, I don't give meds, but I'm helping out in different ways. And then I'm learning now, you know, what the green caps are for, what the purple caps are for. Like it's a new world and I'm learning new things now, which is nice because I kind of felt like I hit a wall on the rig,
sure,
you know, but like in the ER, I'm helping out in different ways, which has kind of gotten me out of that I hate my life
yeah,
kind of section, you know what I mean? But yeah, like everyone's been so welcoming, which has been great. Even the nurses thank me when I help them out with something, or, you know, the techs will sit there and help me out and I help them out all the time. You know, it's a lot more calm, you know? So no, it's been wonderful. It's definitely different because like I said, you know, on a rig, you give meds, you do this, like boom, boom, boom. On a hospital, it's nice steps. You know, you have nurses for this, you have PAs for this, techs for this. Everything's nice and organized.
yeah,
And then it's like it's not even a chaos. Everything's nice and controlled,
yeah,
which is nice. So it's been a nice change. Very relaxing.
So what do you miss from the street?
Well, my honest answer, nothing.
Really?
As of right now, I don't miss anything. I don't know if it was because of the company and just because of all that crap that went down, but right now I don't miss anything.
What could you see yourself missing in like a year?
I miss the people. I mean, I honestly miss the people. Like I miss my old partner. I miss all the great medics, the great EMTs, you know, seeing them all the time. But I mean, I haven't gotten an adrenaline rush in like 7 years. Like I just stopped. I guess the thing I'd probably end up missing is like having my scope and then using it. You know, like we get there, someone's CHF exacerbation, cool. I'll get the CPAP ready. We'll do the stuff. But, you know, because like I said, I don't really give meds at all in the ER, which is fine. So that's probably one thing that I'll end up missing is, you know, administering stuff. But as of right now, I don't miss it at all. I really don't, which is just nice.
Well, it's nice to have a new challenge and learn a whole kind of different skill set and a whole different part of emergency medicine. I think is kind of nice.
Yeah,
and it gets you out of kind of the monotony of what you were used to before. So
yeah, and like I said, that's been the nice part. Like I said, I'm learning new things. Like, because I've always known what troponin was, but now I know how to use an iStat. I know the levels of this.
Yeah.
You know, I know where the helipad is. I know where to go get blood, whole blood, O negative blood. You know, I'm learning new skills that, because like I said, I think I hit like a wall where I used to work on the rig. And now I'm learning new things, which is great.
Yeah.
And it's been amazing so far.
Awesome.
Yeah.
Sarah, did you work in the hospital as a paramedic?
I did.
Do you want to talk about?
I did.
Why don't you talk about the difference too? Because a lot of paramedics wonder the same thing.
So for me, I kind of put my end goal on the back burner just for family and things like that. But I left the field for a paramedic position in the ER so that I could get experience and then do like a nursing bridge and then nurse practitioner, which would be my end goal. Is still something that I would like to do in the future, but I didn't really like working in the emergency room. There were cool parts about it. I learned a lot. I really loved it. Like my coworkers were great. Good doctors, like that was all great. But my scope of practice was so small. It was very frustrating. And I'm really competitive and kind of like a go-getter. So I want to do all the things and I want to learn all the things. So I actually felt like that position was really limiting for me. And I wanted to give more, but I couldn't. And so I was just very frustrated. So it was like, just not for me. I went back to the field and I've just never been happier. So.
I think I see that a lot. I think because paramedics are such a new thing to the ER, nobody really knows how to best utilize them. It's like, because paramedics and EMTs, for that matter, want to be autonomous. They want to be assessing patients. They want to be using their clinical skills, and they're not necessarily utilized in the ER. Because it's like, I look at it as a paramedic's an extension of the physician in the field, because you can't have physicians in the field, right? It doesn't make sense financially. But what happens when you put a paramedic in the same ER as a bunch of physicians? Their skill set kind of is redundant, right? I mean, because we don't need you to assess a patient. There's a provider to do it. And so I think it's like ERs kind of need to figure that out and figure out how to better utilize paramedics.
Yeah.
Because I don't know, everybody goes to EMT and paramedic school to get that autonomy. Like, you're in the field making all these decisions on your own. You're not calling a doctor every 5 minutes to figure out what to do. Like, you just figure it out on your own.
Mm-hmm.
And I feel like that kind of doesn't get done in the ER. I thought maybe that's what Nate would say. He knows this from the field.
No, that's very weird to me. Oh, sorry. That's been very strange to me too. Because like I was up in intake for the first few days and, with my preceptor. And then that's the one thing I noticed, like there's no assessments. Like as techs, we do IVs, urine and stuff. But like I still find myself asking like, oh, what's going on? When did this start? Like I'm still in ambulance mode.
Mm-hmm.
And that's one thing that's definitely weird to me, is that like literally just like what you said, there's just no assessments from like us.
Mm-hmm.
And I still do it. And then like whenever a provider does show up, I'll give a full report. And then my preceptor's like, you don't have to do that. And I'm like, I'm sorry, man. I think I'm still in ambulance mode.
Right.
Because if I see something, I want to know the answer to it. And then if I get the answer to it, I have another question for it.
Right.
But yeah, I definitely forgot to mention that. That's been weird. Just a very odd change.
Mm-hmm.
It's just two very different environments.
Yeah, two
There's
different
so many cooks
worlds.
in the kitchen in the ER.
Yeah.
It's just you and usually 1 to 2 other people outside.
Yeah.
Well, if you think about it, paramedics, their skill set is so similar to what a doc does anyway, right? So what do? Our job is to assess, do airway. That's the big one, right? Is controlling the airway, giving the drugs, finding what's wrong, and then acting on it instead of going. I mean, in our system, this is not a Mother May I system. It's we don't call in for anything in this system at all. We never call in for orders. And so in the ER, you've got physician, nurse practitioners, PAs that are telling, that would tell you, okay. and the docs don't get a lot of intubation time really, because a lot of the patients are intubated when they get there, so they're scrambling to get the tubes, the nurse practitioners are scrambling to do the procedures as well. And the PAs are scrambling to do the procedures. So, and the paramedics do a lot of those same procedures. And so there's not a great place for them right now.
Yeah.
At least not as shops as big as like where we're at.
No.
I don't know what it would look like elsewhere.
I think in a like a one doc ER.
Rural.
Yeah. Because I've actually seen that here. We used to have a community hospital here that had, a couple of arrests, like recess rooms and stuff. And I've been in those places as the ambulance guy, bringing patients in and then helping the doc do central lines and intubating and, venting chests and so on and so forth, because he just didn't have hands.
Yeah.
But now we've got nurse practitioners and PAs in every ER, and so they're doing those things.
Yeah.
So,
Well, yeah. And I think in a system like ours that's so big and has every resource imaginable, I didn't do a chest tube for 4 years because we have a huge trauma service, and any trauma that comes in, I didn't even have the opportunity. I think I watched 1 or 2 and I never did one myself until recently, just because we have so many resources, I don't have to do them. So yeah, that's a good point. I mean, some of it is our system. I think probably paramedics utilize in smaller ERs maybe get to use their scope a little more, but
I will say, even though it wasn't for me, I still learned a lot. And kind of one thing that you miss in EMS is that you don't really see like the long-term care. Like you do what you need to do in the field, and then you drop them off, and then you don't really know what happens. So that was a cool part about working in the ER, was being able to see everything that they do after we bring in a patient. And so I've been able to kind of hold on to that and then take that back to my field practice. And I'm like, oh, you're going to get all these tests. Like, these are reasons you should go to the hospital that maybe I wouldn't have considered before, and now I do. Yeah. So, and then learning what the labs were for. Whenever I was working in intake, I would just be like, what's going on today? And then, oh, the doctor's going to order these labs, so I'm just going to draw them right now.
Yeah.
And they were ready. It was like a game.
Yeah.
But that was the most excitement that I got out of it. Otherwise, I was just like, I need to find a different job.
Right.
So it's just the job. It was not anything else.
Right.
Yeah.
I'll give you that. I can't put intake and excitement in the same sentence either.
No.
That's fair.
I started a lot of IVs.
Everything you hear today from myself and my guests is opinion only. It does not represent any organizations or companies that any of us are affiliated with. The stories you hear have been modified to protect patient privacy, and any resemblance to real individuals is coincidental only. This is for educational and entertainment purposes only and should not be taken as medical advice nor used to diagnose any medical or health care conditions. So the first main topic I wanted to talk about was principles in emergency medicine. I feel like after you've been doing it for a while, you kind of subconsciously discover these. And I'll just start with my two that I have kind of been thinking of, and I have a lot of them. But the main two that I kind of wanted to bring up today, I'll just kind of lead with a story. So this was a patient probably like a month ago, comes in with shortness of breath, chest pain, they're elderly, their heart rate's fast, they're hypoxic. A patient that, a PE should be pretty forefront on your mind, right? They've got the symptoms, the chest pain, the shortness of breath, they've got the vital signs for it. It's somebody you wouldn't even want to order a dimer on, like you just need to get the scan to rule in or rule out the PE. So the patient comes in with chest pain, shortness of breath, they're tachycardic, they have a low oxygen saturation. So I order a CT to look for a PE, mainly because when I'm looking at a patient, I don't ask what do they have? I ask, what do they need? What workup do I need to order on them? And I think that's an important distinction because a CAT scan is also going to rule out a bunch of other stuff that could be causing their symptoms. So they need a CAT scan of their chest to rule out some bad stuff. Primarily a PE is what I'm concerned about. And so I ordered the PE study and they come back and they have a pericardial effusion, fluid around their heart. Trying to use some non-medical terms for our people that, not for you.
Oh, okay, fuck me, I guess.
Bilateral pleural effusion, so fluid in their lungs. And so this patient needs oxygen. They have fluid around their heart, fluid in their lungs. They're going to be admitted, right? There's nothing we really need to do in the ER to address this, but they're not going home. Disposition's done, right? So I talk with the hospitalist and I say, patient's tachycardic, their oxygen's low, they have fluid around their heart, they have bilateral pleural effusions, would appreciate if you'd admit. And they go, well, what's the diagnosis? I'm like, well, we don't diagnose in the ER really. I don't care what's causing and given he's right? A pleural effusion isn't really a diagnosis. A pericardial effusion isn't really a diagnosis. Maybe there's a diagnosis underlying all the stuff that's causing it, but I don't care what that is. And this hospitalist is newer and he doesn't realize the fact that in the ER, our goal is not to diagnose the patient. Our goal is to rule out all the dangerous stuff, decide if you're safe to go home, you need immediate intervention, or you need to be watched in the hospital and they need to figure stuff out. And this patient needed more stuff figured out, but that's not our role in the ER to diagnose. So my first principle in emergency medicine is we do not diagnose. And I think when you approach with that attitude, you can stand in the room for a half hour asking question after question and agonizing over what's causing the underlying condition, but that's the wrong question in the ER. We're trying to just rule out emergent stuff. And you're either safe to go home, you need to be admitted, or you need something emergently done. And that's what we're there to figure out. We're not there to diagnose, these zebra conditions that, unless it's something that's life-threatening and it's a zebra condition. But if it's not life-threatening immediately, we really don't care. So that's something I think we have to set patient expectations for too when they are early in the visit. When you're here for chest pain, I'm probably not going to be able to tell you what it is, but I'm going to tell you a bunch of stuff it's not and that you're safe to follow up with your primary care doctor. The second principle I've discovered is that you need to take care of yourself before you take care of patients. And I think when I was a paramedic, I rarely did this. I would work way too many hours. I was focused on school. I ate like crap. I never drank water, never exercised. It was all on the back burner. And I think that bites you after a certain period of time. And what I've come to realize, especially in the last few years, is like when I come to work and I'm eating terrible and I haven't slept, like I don't do my patients nearly as much good as when I come to work, like having gotten up early and hydrated and exercised, and then I'm ready to go and I can think clearly. And so I think it's a really big point in emergency medicine that you can't let yourself go in order to properly take care of patients. And I think too many people in emergency medicine, don't give themselves the first priority of the day when they need to. So that's my second principle. But I'm curious what your guys' thoughts are on this.
Calling somebody.
Sarah.
Okay.
You would volunteer.
When we have new people on, we tend to talk over them for a while. So we'll talk to you guys first.
For me, I do try to stay like physically fit. I run a lot, work out. Sometimes I still play soccer. So I try to do things that I still like that doesn't have anything to do with my job, because you have to have an outlet that's totally unrelated to that.
Yeah.
That's like the main thing. I really try to be healthy for the most part, just because I feel better. And I'm kind of along the same lines as you. I think that if I'm taking care of myself, I can take care of, my kids better and my family better and my patients better. So that's always been on the forefront of my mind since I started, really. So
I'd be willing to guess that a lot of specialties in medicine, no matter where you are or even in the field, people would do better with the people they take care of if they took better care of themselves. But I will say, I think emergency medicine in particular not only can dominate your life in some way, shape, or form, trying to learn it all, do it all, work more, everything that's requested of you, right? And at certain levels, you'll see shortly going into nurse practitioner world. There's also admin stuff you're not qualified to do and whatnot, and the voluntolds, and would you mind teaching and giving a lecture as well and whatnot, all things related to your job. So there's no real room unless you make it to have a breather, and rather quickly it will get the best of you even if you don't see it coming. I went into this with a real up and up attitude, and my pre-med advisor actually told me before I disappeared to go off to med school, he said, just remember, medicine in general is like a mistress. It'll take whatever it can get from you, and don't expect a lot in return. You're going to have to make time to take care of yourself. And nowadays, my wife will tell you, if I don't go throw around some weights or do something that looks like a task where I'm prioritizing myself for the day amongst all the things with family and job and otherwise, when I set aside that time, it's because my sanity is on the verge of not doing well. My patients tomorrow will suffer if I don't use the last of my energy to go to the gym tonight after a shift.
And your nurses.
And the nurses and everyone. People suffer, right? We suffer together in the ER. So that's also unique to emergency medicine. We all suffer together.
We
So
all
be nice to
suffer.
one another.
And your text, damn it.
Everybody. It just keeps rolling.
Everybody.
Yeah. So I think in this field in particular, it's important to remember that one because it'll get you. It'll sneak up on you. You won't realize how tired you are. I can do anything on 5 hours of sleep. Not for a week or two straight. All of a sudden, you're there, you're present, but you're going to miss something. And depending on the level you're at, you might hurt somebody.
Mm-hmm.
Yeah.
Well, they say like if you've been up all night, when you're driving home, you're like the equivalent of a couple beers on board. I mean,
Those studies are
or
impressive.
more.
Yeah.
I mean, so
Yeah.
sleep deprivation is like huge. And you can feel like when I work 10 hours in a row, towards the end of that shift, I mean, I can feel my brain getting sluggish, especially if it's been high acuity patient and you're looking over stuff, trying to analyze stuff. It's like the end of the shift, you're like, oh man, my brain is fried.
Yeah.
And do an intake where you're going to see 80 patients in a day. You don't want to talk to another living soul for
You
24 hours.
You don't.
There's a great book out there. It was written by an Army colonel, psychologist. Can't remember his name. Colonel something. I know
Colonel
that-
Sanders.
No, I'm Colonel Sanders. I'm actually Colonel Santa. I deliver chicken to the good little boys and girls at Christmas. No, it's called On Combat. And Grossman, I think is his name. Colonel
Yes.
Grossman. Anyway, and they did a study about sleep deprivation, and they took and studied, what's it called? My son would be really upset with me.
Insomnia.
Mortar batteries. And so they would have these different mortar teams, and they would do their accuracy and their efficiency from dropping the mortar round in, firing, hitting on target. And they took these groups and they said, okay, this group's going to sleep their allotted, 10 hours a night before, and then we'll cut it down to 6 hours a night, 4 hours a night, no hours, and then see how they do. And it was from the 10 hours a night or whatever it was, the most, to even the second most, their efficiency dropped by 30-40%.
Wow.
It was crazy. And it's just because of sleep deprivation.
Yeah.
And, so it translates across every aspect, not just combat, but and that's basically what we're doing anyway, is combat. But
Yeah. Well, I feel like you can't, like our job, you have to be like so on the ball, because every next patient might call on every skill you've ever learned and everything you've, academically, things that you've learned. And, I think every next patient's that way. So you got to be on it.
Well, and we get lulled into a kind of a quietness, because, one patient doesn't, you don't have to pull from those skills because the acuity is not
Right.
high, and the next one isn't high, and the next one isn't high, and the next one, you might go a couple shifts with really low to medium acuity, patients. And then you get that one that's high acuity that takes every ounce of your skill. I mean, your toenails hurt because you're thinking so hard,
Yeah.
So there, you just have to be ready for it.
And they'll
it takes a
inevitably
lot
come
of you.
through the door at 8.5 hours out of a 10-hour shift.
Right? Yeah,
Yeah.
exactly.
Yeah.
Or at 3 o'clock in the
Or at
morning.
3 in the
when
morning.
You went to bed and now you have to
You
think,
get it.
You're half asleep just in
Yeah.
the rigs doing
what's
this
going
thing.
on?
Having to wake up to run a call is probably the worst thing on the planet.
Oh yeah.
I do not
It's
miss
I don't
that.
miss that.
You wake up to run calls?
No, not anymore. Not anymore.
Dude, whenever I was there with my old partner, we'd be like half asleep after a cardiac arrest, typing. We're like, what do we do again?
Yeah.
Did we just go through the whole ACLS guidelines?
I got to tell you, I sleep whenever I can.
Oh, yeah.
Oh yeah.
And we were, I can't remember, there was a bunch of us talking the other day, and actually Tracy was there, and they were all amazed. Every one of them that I had worked with, they were all amazed that I could sleep, not driving, sleep being in the passenger seat and go, turn here, turn left
Yeah.
here.
Right.
They're like, how does he know? Because he's sleeping.
Yeah.
I do.
50-50.
Yeah.
I always learned eat when you can, go to the bathroom when you
Yeah.
can, sleep when you can.
Emergency medicine's a lot like being a new parent, which people can relate to even if they don't have kids. People warn you, right?
Yeah.
Sleep when you can. Do things for yourself when you can.
Yep.
Because when you can't, you really, truly can't.
Do you have the Aura ring that watches your sleep?
I don't.
Ooh.
My Fitbit ticks me off regularly, though. If I sleep
So-
in it, it'll tell me how little I sleep.
Yeah, I got the Aura ring. And
Yeah.
comparing my sleep to my husband, who's non-medicine
Yes.
sleep, he's like, holy, you can flip your sleep on and off like a light switch. And
Yeah.
I'm like, I've mastered it
Yeah.
between parenting and
Yeah.
The two of
and
those.
medicine. But truly, if you don't get enough sleep, you're
Yeah.
walk in the room, don't know.
Yep.
Yeah.
Just
For
don't
sure.
know.
Well, most of our patients aren't dying. You don't need to run down the hall to the next patient. You can stop and use the bathroom. You can take some sips of water. You can take some bites of your food. Like, it baffles me, the providers that they're like, I haven't peed in 3 hours. I'm like, why?
Go to the
Why?
bathroom.
The bathroom's on the way to the patient. Just leave it on the way.
It's a rare occasion that it's that bad, I will say. It does happen. Places like the hospital on the North End, for example.
Yeah.
It does
Yeah.
happen
Real good.
occasionally,
Yeah.
but it's not a regular thing. You have to take those opportunities. It's usually your own fault for having gotten so frustrated or tired before you got there or whatever, or mismanaged your time early in your shift with documenting or something you could have kept up with. You've now got the burden of feeling you're behind, and that is our own individual fault in time management. That's usually how you get there.
Right.
Yeah.
No, I like blaming it on the person because we can't. I think, like, what good does it do to blame it on anything else?
Okay.
And we can't
fair.
do a damn thing about anything else. I mean, you can't do anything about the volume. You can't
Yeah.
control the system we're in.
That's
You
right.
can't control any of that. So,
Yeah. What comes through
like,
the door?
blame it on at least something you can control, so you
Fair
can at
enough.
least do something about it.
This son of a bitch. This is why I'm not peeing today.
Aren't you doing 75 hard?
Yeah.
Is that the mental
Ugh.
toughness
Yeah, that's
thing?
exactly why I have
that
Dude, it was just nice. Like my first day with my preceptor, like when he would, like, it was literally like the whole bathroom stuff. He's like, Nate, go take a break. I'm like, what the hell's a break? I was like, is this a drug I need to know? The dose? He's like, no, go take a 30-minute break. Go pee. And I'm like, what?
Well, yeah, it's crazy because
Tired giving you that.
you go, how many times on the ambulance did you walk into the restaurant,
Yeah.
be the 3 back, and you get right there, medic 3,
Yep.
code 3 north.
Yeah.
just turn around and walk out.
Yeah.
I mean,
Dispatcher,
Happens all
we're
the
like, we're stuck in a drive-through. There's
Yeah.
cars behind us. So sorry.
Well, that's
I
fine.
have to
Yeah.
send someone else.
yeah.
We have calls holding, and we need to meet compliance.
Yeah.
Yeah, it's
That's
just.
happened a few times.
Oh yeah.
Anybody else have any principles they've learned in emergency medicine?
I think a big principle is treating them like they're your family. If I wouldn't want my grandma to do it, I wouldn't do it to a stranger's grandma. But also, if the patient's not willing to follow up, if the patient doesn't want it, why are we going to do it? If the patient rolls in, we've had the patients that roll in and say, I'm not spending the night, I'm not being admitted. We can rule out the big, bad, and scary, and we can stop there. If they don't want to be admitted, if they don't want it, don't do it.
Yeah.
If they don't want the IV and the blood work, well, okay, we're just here to offer.
Yeah.
But at the end of the day, that's probably a big principle. You see the ones that get, nurses that get all huffy that they're not going to, the patient doesn't want it and I can't convince them. Well,
Okay.
we can offer, we can risk benefit it, but at the end of the day, it's their decision. It's not my job to convince you. It's my job to do it.
Yeah.
That is a great point that I've never heard anyone bring up in these conversations.
Yeah.
And that will help a lot of people that work in the ER at some point at any level. I can't tell you how many well-educated, seemingly fully functional physicians who are cooking their brain with smoke coming out of their ears for 5 minutes. My goodness, I think I need the AMA form, and I just told them, what if they won't do it, and blah, blah, blah. I'm not being callous to look at them and all my residents and med students, nurses, NPs, PAs, everybody, and remind them of that regularly.
Yeah.
What do you want to do? Does the patient have capacity? Did they hold the conversation with you and say, I know I could actually die from this, or I'll never get the answer I came here for after waiting 5 hours? Yeah, they can tell me that. Now, why are you wasting your time and brain power and burning yourself out to go be irritable with the next person?
Yeah.
You're 10 minutes behind in your documentation right now. Go
'Cause you
click some
have-
boxes. You can't win that fight. That's up to them. If they come back tomorrow, better or worse, you'll also be here.
Yeah.
That is a great point. People do sometimes burn themselves out fighting with patients over things that aren't worth the fight.
Right.
Can they think for themselves? You did your job. Move on. Yeah, that's a great point.
Nobody needs to take, we are, that healthcare is a business. Nobody needs to take our business.
That's right.
We're just here to offer it. We go into healthcare to save people, but at the end of the day, once you get into the reality of it, if they don't want it, that's their choice.
I think that trend to force people to go is kind of turning in the pre-hospital realm.
Yeah.
Because used to be, people are having chest pain and they're having the MI, they're having a stroke, but but they have that capacity to refuse. And we would force them to go, basically kidnap them.
Yeah.
And we're we've turned that corner now.
Yeah.
But I've had a couple cases in the last, month or so that I actually did have to contract medical control just to say, hey, I'm covering my bases. I don't want to leave this guy here. He doesn't want to go. I'm not going to spend an hour trying to convince him, but I'm going to let you talk to him and see if that helps. And one of the medical directors, Matt, got in a conversation with him. He goes, hey, we're not here to babysit.
That's
And
it.
I said, absolutely, we're not.
That's it.
But to quell the apprehension of the rest of the team that was there, I put it in their court so that they could have it. But I was not compelled to take this person because they just were adamant not to go. But they were having the big one.
Yeah.
Yep.
And, that's a choice that they make.
Yeah.
You give them you delineate what could happen, what they're, that could end in their untimely demise, whatever. And you give them all that and they still make that decision, then, bless you.
Maybe it's not untimely.
Yeah.
Yeah.
So
Or maybe
it is. Yeah.
Maybe it is their time.
Yeah,
Maybe
maybe
they
it
want
is.
it to
Yeah.
be their
I
time.
want to die
We
at my
also-
house.
Some people just
Yes.
wanted to know.
Yeah.
Some people just want to know and they find solace that they can go lay down and take that
That's
nap
true.
or
Yep.
not, or,
Dirt
It does happen.
Yeah.
and then
Yeah.
and then you see the nurses or the staff members that are that can ruin their day.
For sure.
And it's, to go back to the burnout, it's like, no, they are on their own free will.
Yeah.
That's right.
Thank God.
Yep.
Thank God it's not my free will,
right,
but that's
right.
theirs.
If you took
It's their
everybody's
prerogative.
burdens home from that side to the
Uh-huh.
other side,
Yeah.
you ain't gonna make it very long. I tell you right now.
Right.
Best intentions in mind, you won't make it very long in this job.
Yeah. If you guys got any value out of this today, if it resonated with you, encouraged you, the only thing I ask is you subscribe to the show, give a 5-star rating and review, which will help a ton. I don't make any money on the podcast, and it does cost money to do it. So if you want to support the show, go to practicalems.com, join the email list, and subscribe on any podcast player. You can find the clip stuff on YouTube as well under Practical EMS. And we will see you guys next time.